must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Thank you again all for your continued support, and now for the show.
Hello, everyone, and welcome to another episode of the Healthcare Education Transformation Podcast. I am one of your hosts. My name is Brandon Pullen, and of course, I'm joined by my other two fellow co-hosts, F. Scott Beal and Stephanie Wyrock, and today we are so thrilled to have two prominent educators on to discuss the topic of reduction and variation of education, and also talking about the flipped education model, as we are happy to welcome Dr. Steve Tepper and Dr. Carol Davis. Now, for those of our audience who perhaps are not aware or who have not heard of these two individuals before, Dr. Tepper is the president of Rehab Essentials Incorporated, which supplies high-quality online PT education in a cost-effective way. The courses were designed and utilized initially for the Transitional Doctor of Physical Therapy program, which is currently at the University of Montana. Now, this transitional program allows PTs to maintain their work-life balance, continue to practice and advance their professional qualifications by taking online courses to achieve their DPT. He is also a freelance professor with the Universities of Delaware, George Washington, Maryland, the Ohio State, VCU, and multiple others. And Carol Davis is a professor emerita and immediate past vice chair of the Department of Physical Therapy at the University of Miami Miller School of Medicine in Miami, Florida. Now, Carol and Steve, thank you both so much for coming on the show today and for your time, as we're so excited to kind of dive into this topic, because I know this is a big one within the education realm. Do you think that you could each kind of give us a brief insight as to your academic journeys, to kind of discussing how it led to where you're at today? And Steve, I'll start with you, and then we'll follow up with Carol.
Okay, I'd be happy to. Hi, again, my name is Steve Tepper. It might not be so brief because I think it's really important that I explain where I came from to be able to explain where this whole thing is. But basically, I graduated University of Maryland back in 1979 with a bachelor's in physical therapy. They knew I wanted to teach, so in 1980, 1 year later, they actually invited me to come back to teach, while then they would pay for my PhD. Those were the good old days in academia when they allowed that to happen. I taught there at University of Maryland. I'm more into the basic sciences. My area of clinical practice then was cardiac rehab and cardiac care and management of cardiac patients. In 1981, I started my PhD in experimental pathology, which I did attain in 1990 from University of Maryland. What happened then is I continued to teach there for another couple of years, but then a small private college moved me away. And so I went to go teach at Shenandoah University in Winchester, Virginia. I taught there for about 12 years as well. I also became the director of the program, which was instrumental in a lot of ways because it helped me also to understand what administration is all about and the difficulty administrators have. In the world of APTA and clinical, I just want to also make sure you realize I went through the different ranks of administrative aspects of the cardiovascular and pulmonary section. And that's important because that leads me to get to be friends with all the people I'm friends with. The one thing is in around 2004, 2005, I started up a company called Centers. When I did this was every year we were always looking for faculty in specific content areas that tended to be deficit in different programs. So, for example, we were having difficulty finding a person who could do imaging. We were having difficulty finding somebody to do pharmacology. We could always find, PharmDs. We could always find radiologists, but they typically did not talk to the physical therapy audience. So what was important to me was we were bringing down people like Lynn McInnes to do the interview. And so I was friends with Chuck Saccone, who does pharmacology. And all of a sudden I went, something maybe what we need to do is record these courses that they teach so that they then don't have to travel and we could have their expertise in other programs. One other thing that was going on was I was being invited to go and teach at many TDPT programs around the country in the area of cardiovascular care. And what I saw is people were paying $30,000 to $50,000 to get their TDPT in these different programs. And I went, this is crazy. We want to actually get many, many people to go for this degree. We should be able to do it in an online way, which is very cost effective. And so that's how Rehab Essentials was born. But thank you for giving me that time to do that sort of long-winded explanation.
No, it was very helpful, Steve, and thanks. We'll ask a little bit more on a couple other things in a little bit. But Carol, how about you? How about your insight into your academic journey?
Well, I was lucky enough to be admitted to the first entry-level master's program following my graduation from college. I entered Case Western Reserve University and got my Master of Science degree and also studied physical therapy at the same time. And I got a good background in science. And so I went off to, I had an undergraduate degree in science, I had a master's degree in science, and then I went off to Mass General and began my clinical work and really loved clinical teaching. And Marilyn Gossman asked me to come join her faculty at the University of Alabama in Birmingham. And I went there as an assistant professor in 1971. I developed that clinical education program. Then I realized I wanted to know more about interpersonal skills because I realized how much clinical education, the success in clinical education, depended on clinical instructors being able to relate well with students and be able to teach the interpersonal rapport building skills with students and also to be able to help students be confident about their skills and their knowledge in team meetings and interpersonal interactions. And so I went back to school to study philosophy and psychology at Boston University, and I received my doctorate in 1982. I did a dissertation on empathy, a phenomenological description of empathy as it occurs within physical therapists for their patients. And then I was hired by the University of Miami School of Medicine to teach the family medicine and internal medicine students and fellows about geriatrics. I was always interested in treating older people, and I headed up the fellowship in clinical geriatrics at Miami. Boston University invited me back to start another master's program for them, so I developed a master's program in 85 to 87 at Boston University. And then I really wanted to get started to write the book about interpersonal skills. So I came back to Miami to write, and I developed my first textbook, Patient Practitioner Interaction, an experiential manual for the development of the art of healthcare. That's now in its 6th edition with Slack. It sells very well. And then I got interested, and then the University of Miami, Sherry Hayes invited me to join her faculty. We developed that master's program. I joined them full-time in 87, and I helped develop the DPT program in 2001 with the faculty. I was the vice chair for curriculum and faculty development. And then I was teaching as we developed our DPT program, we developed an imaging program. Of course, we got Steve to come down to help teach pharmacology. We were fortunate enough to have Meryl Cohen in cardiopulmonary. And that's when I got to know Steve. I was involved with faculty development curriculum and the DPT, but I also was on the Commission for Accreditation in Physical Therapy Education, first as a site visitor since 1985, and I go around to schools recognizing the strengths and weaknesses of different programs. And I was a part of the House of Delegates when we voted to move away from the AMA. I'm really old. We moved away from the AMA. I was very active in the section for education, now the Academy of Physical Therapy Education. And I was developing courses to teach clinicians how to be good clinical instructors. And then I was a site visitor for CAPD, and then I also was invited to join the commission, and I served on the commission for 6 years. And so I have a pretty good understanding about developing the CAPT criteria for accreditation, both physical therapist assistant and physical therapist, about the difficulty around the country with schools trying to hire qualified faculty and so forth. I retired from my administrative position at the University of Miami in 2009, and I retired from my teaching at the University of Miami in 2015, and I was awarded Professor Emerita, which means I'm still associated with them. In fact, I'm going over today at noon to teach the first-year students about fascia. I like to teach in complementary therapies, in understanding the magnificence of this connective tissue that we all have, this wonderful vibrating fascial web. And I also teach a myofascial release weekend elective course with them. And I teach in ethics and interpersonal skills. So I'm still very involved as a faculty member, even though I'm not there full time.
Wow, I was going to say, wow, quite an impressive bio from both of you. I mean, wow. I mean, my mind was spinning the first time I kind of heard, like, wow, they've done all this stuff. Holy smokes. So, Steve, I wanted to go back briefly and ask kind of a follow-up on rehab essentials. As you said earlier, it's kind of a way to start to get the transitional DPT more accessible so more people could do that in a more cost-efficient manner. But of course, now seeing that it has expanded. And, do you think you could tell our listeners kind of what the company has added since starting out and kind of what it looks to add in the future?
Happy to do that. And so basically the way that I looked at Rehab Essentials is if we do good quality programming, if our faculty are outstanding, they present the way that they do, that basically these courses, all of a sudden what happened is people found out that we were offering these courses in our TDPT. And suddenly what happened was other TDPT programs started to say, hey, can we utilize those courses? So we started to sell them to other universities. And then what happened is other entry-level programs started to say, wait a second, I would be interested in having Bill Boisnall teach screening for medical disorders, Lean Farron talking about coding and reimbursement. And what has happened is other universities are using them as well. So we license them to universities for their use. Well, then what happened is then people all of a sudden started to say, hey, I wouldn't mind taking this as a CEU course. So all of a sudden, people started to take it through the APTA. We have a relationship with the Learning Center. We also sell them, even on our own website. So that what we have is basically CEU people taking it for that as well. They're being used in residency programs. They're being used in fellowship programs. So the course, which is a good, solid, I want to back up and make sure I make this statement. We really like to call them modules versus courses. Because one of the things that we really did not want to happen is people would take Chuck Saccone's pharmacology course and just use it as a plug and play in their institution. We really feel it's critically important that if you are in an entry-level program, that when you use the course, you need your own faculty to bring it alive with high-impact learning. So, in other words, Chuck would teach the basics, with pharmacology, beta blocker, slows down the heart rate. But then what the faculty at the institution need to do is they need to then bring in cases, talk to them. This is why the person would be on this beta blocker. But then what's happened is it's really kind of expanded from there because now we have different countries calling us. So I'm going to give just two quick examples. Thailand, they flew me over to Thailand, and basically what they wanted to do is they wanted to move Thai PT to the DPT. So I spent a morning talking to all the program directors and faculty about the move to the DPT in the United States. As it happens, 14 of their faculty from around the country are actually taking our TDPT program back here in Montana. But what happened is their higher education basically said, we're not going to allow you to offer the DPT. So what they chose to do is utilize our courses in their master's program. So one of the things that I feel is important is we're trying to spread high quality professional education to the world. As to whether they offer it as a master's or doctorate, that's up to them. Whereas the Philippines, we have quite a few Filipino physical therapists in this country. Well, many of them have taken our program, and they must have contacted, and we received information from somebody, contacted a university in the Philippines that wants to partner with us. So what that means is we're working with that group. They will take care of the admissions, different aspects like that. But we're going to funnel those students through the University of Montana TDPT program. We might have to change a couple of the courses a little bit, but at the same time, what's happening is the world is starting to say, what can we do to improve our profession? And I love what Thailand is doing, and I really enjoy working with the Philippines as well, what they're doing. The other thing, just one last thing that we're also expanding into is certificate programs. What that is suddenly we realize, and this happens to many PTs, they go from being a staff PT to suddenly they're moved into an administrative role. They usually get no training as to what does it mean? What do you have to do? So we started what we call a Rehabilitation Administration Certificate. It's run by Mike Friedman from Johns Hopkins. It has Alan Jetty. It has Mary Skilfin from the Cleveland Clinic. And what they do is they try to educate staff therapists. Here's some of the things you're going to have to do as an administrator. And so we're working that way. We're doing a population health certificate with Jennifer Gamboa. It helps, therapists that want to move into that wellness health commercial area. And then finally, we're doing a health sciences education leadership certificate. And that's run by Mike Emery and Barb Shopey. And what they're doing with that is they're taking PTA directors. They are now required by CAPTI to take 9 credits worth of material, college credit, to help them learn how to do evaluations, how to do faculty evaluations, how to go about doing, objective writing, how to test writing. Because that's another thing that happens is you graduate. Like, for example, I got my PhD. I was never taught how to teach. So one of the things we're going to do is we're going to expand this program into new PT faculty so they can learn also how to write test question objectives. So we're trying to think of what are some other areas that we could be helpful to them.
I think that those are some really innovative ideas that you have, Steve, and I really think that it's cool that you've expanded into all these different areas. Our topic for today's episode is standardization of learning and the flipped education model. And there are probably some people listening who maybe don't really know what these terms mean. So do you think you can clarify what these terms mean? Let's start with you, Carol, and then we'll move to Steve.
Sure. The flipped classroom is pretty easy to understand. It's just as it sounds. It's inverting the classroom so that events that traditionally take place in a classroom, the sage on the stage with PowerPoint, now takes place outside the classroom. Students do this on their own with their computers. And then they come into the learning environment inside the classroom for interactive work, small group work, questions, discussions, seminar kind of going more in depth into the material. The standardization in education, Steve prefers, and I do too, the term reduction in variation in learning. What I found out when I was doing my site visit with CAPTI, all schools have to do a self-study, and the faculty has to describe how their particular curriculum meets the educational criteria set up by CAPTI for meeting accreditation standards. They write this down, and they do all kinds of surveys and documentation. And then the on-site team goes to the school to talk to faculty, to talk to students, to talk to clinical faculty, to see how they're actually doing this and whether what they put down on paper is really the way the picture unfolds in person. Virginia Nealand, one of the very first, I think she was the first director of the Commission on Accreditation and Physical Therapy Education, always had a saying, when you've seen one physical therapy program, you've seen one physical therapy program. And there was a great amount of pride amongst faculty that we're going to do it our way. We're going to focus on the strengths of our faculty. We're going to meet the needs of our particular community. And there was a lot of justifiable pride in that. Unfortunately, sometimes the criteria demanded that students learn content, and faculty were not very well prepared to teach it. And so the students came up short, and there was a lot of variation in the quality of education. And this became even more dramatic when we started moving to the DPT level, where we added more pathology, we added more imaging, pharmacology, clinical problem solving, when students were being taught by faculty who did not have training in education at this level. Experience made up for some of it, but not all of it. They had to go back to the books, and there was a real variation in how well, especially clinicians, were picking up this academic work and trying to convey it in the classroom. And that's why the stars became even more famous. The Chuck Sacones and the Steve Teppers and Catherine Goodman teaching PT diagnosis. There are a few people who did the academic work, and then faculties wanted them, because clinicians don't like to do that usually. They don't like to have to go into that kind of depth. So we're trying to reduce variation in learning by being really, really clear at the House of Delegates level, where the House of Delegates approves the educational standards that are adopted, the normative model of PT education, physical therapy education, and physical therapist assistant education is what it's called. Then CAPTE has to set the educational criteria that say, okay, if you want to meet this normative, this model of what you're supposed to be doing in your curricula, this is how you're supposed to do it. And CAPTE has become a little bit more prescriptive out of pressure from the profession, that students were being graduated and they weren't qualified.
How about you, Steve? How do you define those terms?
Well, to me, the flipped education is exactly like what Carol just said, which is instead of having the sage on the stage talking in the classroom and everyone writing their notes, they can do that at home and have the content expert teaching them, but then they come into the classroom and the classroom flips. And instead of the person just being up there giving basic information, they make it fun for the students. So what you do by that is all of a sudden you start throwing out cases. You start saying, okay, call me. I'm the physician. You think this person is overdosing on this certain type of drug or reacting incorrectly? Please, let's talk about that. And you role play. So it's higher level education. It's interactive. And trust me, the students engage with this and enjoy it quite a bit more. So that's that flipped education. And I agree absolutely with Carol. Instead of that concept of standardization, block, everything's the same, I go reduction and variation. And please, I teach at many, many programs across the country. There are strengths and weaknesses with each one, but there are gaps that are there. And when you see those gaps, they can be very glaring. And I'm going, we can do something about this. We can have every single program, if you want. You could have Chuck Saccone teaching your pharmacology course to allow you to understand at least the baseline of what we think all therapists.
Yeah, Steve, you bring up a pretty good point there with, reduction and variation in DPT programs. I'm curious what you guys think the current level is at. You've seen a bunch of programs now across the country. How are we doing as a whole? Are these DPT programs hitting the mark, or, do we think we need a pretty big overhaul with the level of reduction of variation?
Since I do teach in quite a few programs, the one thing that I would say is we're not doing as good as we could do. And that's just it. With technology we've got now, we can do much, 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 much better. So there's some places where I go where they go, oh, they had a pharmacology course. But the pharmacology course was not geared to PTs, and I just ask what I consider straightforward questions when I'm teaching in the cardiac area, and I can tell they really don't have that understanding. Like Carol said, CAPTE tries to ensure this. Ensure they're doing the best job that they can do. But at the same time, when you go and spend time with the students, you can see these areas that are just missing. And I'm going, we can handle this if people, to a certain extent, maybe dropped a little bit of their pride. And I do want to go back to that one that Carol made that statement about each program has their own pride, which I understand. But boy, why not have Chuck, Bill, other people teaching in your curriculum, but then make your faculty bring it up from there. And then we would be sure the baseline is met with all programs.
I think that it's really interesting how we're talking about reducing the variation within programs. I know that this is very common also in a lot of medical schools where they're doing the flipped classroom model. And I'm wondering, what are your thoughts, Steve and Carol, on how the flipped classroom model reduces variation in programs?
Well, the strength of the flipped classroom is that you can go more in depth and use cases and have the students rehearsing in the classroom before they get out into the clinic. We didn't used to be able to do that very well. When I taught communications in physical therapy education, I realized that what the students needed to be able to do would be able to on the spot handle a patient who's raging in their face, or a patient who's depressed, or a patient who comes on to them inappropriately sexually, or a colleague. And they didn't have practice doing that. So I stopped lecturing totally. I gave them the classroom assignment and the slides on Blackboard. And when they got into the classroom, they knew that they were going to be doing small group work. What happened was they did the small group work. Even the students who were reluctant to take the course because they thought it should be an elective, and it's not at Miami, they had to learn these things. They would come back from their clinicals and almost to a person would say, I had every case that we practiced in the classroom happen to me when I was on my clinical. And am I ever glad I had some feeling of where to begin, because I would have just been overwhelmed if I hadn't had some way of practicing. Now that's just one course. To me, that is the statement that would say, let's do this across the board. To me, that's where you're going to raise the standard of performance with students.
Well, the simplest way that I think is if every single person did have, and I know I'm using Chuck Saccone's course as an example, but if everyone did have that pharmacology baseline knowledge that he teaches in a well-organized course, at least we'd have that standardization or lack or reduced variation in that material that is being presented. But I'm seconding what Carol is saying, and that is, I think the nicest compliment I ever get from students is they go out to clinic and they go, I felt incredibly prepared for the clinic, because again, the way that it's taught is that flipped education. They hear the course, they understand it. I try to bring in the aspects of what the clinical world is going to be like, role play, do that, and they come back and they just go, that's the best thing, is I feel like I'm prepared for that clinical.
So we've been talking a lot about this flipped education model. We've been talking about reducing the variation within programs. What are your guys' thoughts as far as pros and cons go for standardization of learning or standardization of curriculum, or as you have defined it, reduction in variation?
So I'm going to keep it real simple on this one. I'll just have two pros and one con. And that is, pro is students learn at their own pace. In other words, when they're taking the computer modules at home, usually they have a week long to do it when they want to. So they can do it in their pajamas, they can do it out on the beach, they can basically sit anywhere as long as they can focus on the material. So learning at that pace, and if something comes at them on a slide that they don't understand, they can watch it again and again and again. And certainly when you come into the classroom, you always start out by saying, are there any questions that you had from the presented material before you jump into role playing and some of the other stuff? The other big pro, the way that I see it is now faculty don't need to waste a lot of time on that basic content because it's already being delivered by somebody who is the content expert. Instead, what this does is it frees faculty not only to be more interactive in the classroom, but it frees faculty for scholarly, productivity, and many other things that faculty really need to focus on. The con is, there's no question about it, some students don't like taking material on a computer. They go, I'm paying for this. Why aren't I getting a live teacher? Well, the reality is, you're getting the best content from a well-organized person who's been teaching it probably for 20, 30 years, is very well versed in the area. And that the other thing that's tending to happen nowadays is less and less students have difficulty with computer. So as we are evolving to a certain extent, younger students, they just see it, and guess what? They just take it, they suck it up, and away it goes. So that would be my con right there.
What about you, Carol? What would you say the pros and cons are?
Well, I certainly would echo what Steve said. I always am concerned about the quality of evaluation. The students need to be evaluated for competence before they go out into the clinic, and the faculty faculty will be held accountable for evaluating them to be safe with patients, but also to embody the core values of physical therapy. And that really takes place best in an interactive style with faculty teaching this content, teaching about the values, teaching about interaction, teaching about and evaluating their skills in this area, but also mentoring them and modeling this behavior. If we get faculty who are too dependent on subject matter experts to put forth the content and aren't doing their part of modeling the appropriate behavior and mentoring the students and following up with educating themselves on the content so that they can fill in the gap, then you're going to send students out that aren't totally prepared.
And I'd love to just add this. One of the things that I like is in front of the students when I'm doing the back and forth, one of the things that happens is I can say, I don't know the answer to this. And I can go look it up and I can spend some time and model that behavior for them, because even though they think oftentimes we are that sage on the stage, the reality is none of us knows everything. And so even when they just see that, I think it's a wonderful experience.
Yeah, that's a great point, Steve. And Carol, to your point as well, I mean, as an educator, why would you be worried about somebody else? I mean, the content's already there for you, given by an expert. Take it and run with it. Like, why be afraid of that? Like, that's less work for you, you know? So it just makes sense.
I'd also like to comment on the fact that, you know, some of the things that you are describing reminds me of how the Toyota model of perfecting the work. So in Toyota, many of you probably have heard this, but in Toyota, you continue to work on a specific part of the assembly line until you perfect it, and you go at your own pace. And once you master it, then you move on. And that's kind of what this is sounding like to me. Once you master this specific content, then you're able to move on to the next part of the curriculum. And, you know, people do learn at different paces, and faculty have other responsibilities. And I think that this model seems to solve a lot of those problems that of concerns that people have had just in education in general.
Another thing that is faculty comfort level is not, it's a process to learn how to do this. This is, I mean, if you're used to 20 years of being sage on the stage and all of a sudden you're now asked to interact with students a lot, that's not your comfort level for many faculty. So one of the things that I think is important is yeah, they might have to bone up on some of the material because Chuck teaches at this level or Bill teaches at this level. They have to look some things up. But at the same time, boy, to me, it's so much more fulfilling when I get students interacting with me versus me controlling.
I think it also really fosters a collegial relationship with faculty versus the student-teacher relationship. I mean, we all graduate from PT school becoming physical therapists, so that I think that relationship between colleagues is really important to develop. And I think that is lacking a lot of times in programs just because you're used to this teacher-student relationship. And then once you graduate, because you don't have a great relationship as far as collegially with your faculty, maybe you aren't developing some of those relationships that may be important later on and continuing to develop yourself as a physical therapist. So I really like that point that you brought up, Steve.
Right, thank you. Well, one other thing I just wanted to say about Scott, why aren't groups using this? In other words, why doesn't every university use it at this point? The biggest reason I think that I'm going to probably say is people will say money. And the thing that's amazing to me is we are incredibly cost effective. The price, it's probably cheaper than if you were to hire somebody to come in and teach your pharmacology. It's probably cheaper than that. But many institutions, financial, they don't have support for this. And they go, I have a faculty, they're supposed to teach everything. They have to teach everything. So I can't afford to do this. The reality is guess what? Especially if they buy 3 courses, it gets very much reduced in rate. So we're doing it in the best way we can to make it sustainable for program.
Yeah, I think that's a really big pro, especially at the end, because I know that again, not being too much in the academic route, but knowing that there's a lot of other variables in play, and especially finances definitely being up there as well. And, you know, we've talked a lot about a lot of the things regarding what this model specifically is with reduction in variation and kind of this flipped education model. And there seem to be a ton of pros and a few cons with it, but To play the other side, there are also, I know some people out there that kind of criticize a model like this, and that might be just partially due to misunderstanding. But, we've heard things such as, it severely limits the opportunities for students to learn by kind of enforcing a one-size-fits-all curriculum. A certain level of standardization deprofessionalizes teaching by marginalizing professional judgment, experience, skills of teachers. And even others would say, too, that standardization tends to shift professional practice towards content coverage, and away from deep understanding. So, and I know we have talked about a couple of things further that kind of go against this, but I'd really be curious, because this is sometimes what people think. What are each of your responses to these critiques from others? And Carol, I'd like to start with you on this one.
Well, I believe that people who have those kinds of criticisms are looking narrowly from a defensive stance. They're trying to protect their own turf. They're not opening their minds to look at all the possibilities. We've already talked about the fact that that students get a deeper understanding with the flipped classroom because they can delve into the material more, but the demand on the faculty member is that they have to be prepared in a different way. So a faculty member who doesn't want to do that might come forward with this kind of criticism. But the research shows that the students really do enjoy the flipped classroom, the interaction in the flipped classroom, much more than just taking notes from PowerPoints. And content coverage versus deep understanding, the deep understanding comes when they have to grapple with the material. And you've got the very best up-to-date academic content being presented outside that you can take in on your own time. Those are, I think, red herring kind of complaints from faculty who really have a kind of a conservative view of what college education should be. And they're not keeping up with demands of healthcare or education in a way that allows them to be flexible and spirited with the maneuvers that they're using with students. Sounds a little harsh, but as you can tell, I really have, because I've used the model, I'm very, very committed to it. And I've for years seen feedback from students, both while they're students and after they graduate, as to the benefits, especially for the flipped classroom.
So you guys have talked a lot about some of the things that potentially are lacking in DPT programs. So you've mentioned that the faculty maybe don't have as big of an understanding of things that they probably should, that there are some lack of content teaching within different programs. So you've mentioned some problems facing academic programs, but is there any other problems that you notice that maybe we could address in this talk, being academia professors yourself, that maybe are facing academic programs across the board besides the ones that you've mentioned?
I do think at the moment we're in a very interesting place, and that is there's more PT programs that are being created. I think it's probably like almost 20 programs, if not more, in the last couple of years. There is not a lot of highly qualified chairs or directors. There is not right at the moment highly qualified faculty to teach at, we're at more than 250 programs at this point. And so, I look at this and I start to go, if we're trying to train healthcare professionals that are going to have to interact with their patients on a day-to-day basis, we need to do something to up the level of the education. Increasing the numbers of programs is not upping our level of education. I mean, we're processing and have more PTs being graduated, but at the same time, are they really now at a higher level, this DPT level, given what I consider possibly not enough really good qualified faculty? And I want to make sure that, because I imagine there will be people in the audience that are faculty, I'm not trying to hit on any one individual. That's not my goal. I'm actually just trying to go, who would not want to have some of these experts as part of your program, and then you bring it up from there? I mean, to me, it just makes so much more sense.
We've heard that statement many, many times on this podcast that, with the proliferation of programs, it's really difficult to find faculty that are qualified to teach. Carol, is there anything else that you want to add to Steve's point, or any new points you'd like to bring up?
Yes, actually, the Catherine Worthingham Fellows after Jim Gordon's Mary McMillan several years ago had almost like an emergency meeting and called for a moratorium on the development of new programs and suggested strongly that the House of Delegates put forth a motion to stop all the development of any new programs because of the severe limitation of funds for existing programs, because government funds especially were having to be distributed to programs. They had pass rates that were less than 50% after 3 times on the licensing exam. It all boils down to me as a severe breach in ethics. College presidents and provosts decide this is a good way that we can make money for our university. We're going to hire a clinician and we're going to go to CAPTI and make a declaration of intent and pay this clinician to start a program. The clinician is bored or burned out and said, well, I'm ready for a change. They aren't educated in what it means to be an academic. They don't have a PhD. They go back to their own class notes. And at CAPTI, we actually got course syllabi that had other university names at the top whited out and the current university typed in. And it's just a copy of the course notes that they had when they were students. And they were using that as their classroom material. To me, that is a severe breach in ethics where students are being used as a means to an end to make money. It's bad enough in our practices when we use patients as a means to an end to make money. But now it's evolved so that these new programs are being started. Students are being invited in under false pretenses because you have to actually admit a class before you're accredited. You've stated your declaration of intent, but you haven't been accredited yet. And you have to state to the students when they're being accepted, but they'll go anywhere that will take them. They're so desperate. And then you have to have a plan for what you're going to do with them. And there was a considerable amount of time at CAPTI of doing these revisits to these programs that weren't qualified, that failed their accreditation process. And where are we going to find a place to put these students now, because they've already paid $20,000, $30,000 and their education is worth nothing. So to me, it's a severe ethical breach and something really needs to be done. And I think what Steve is doing is a tremendous benefit, but I think the problem is much, much bigger than that.
Yeah, Carol, I mean, you guys both bring up great points. And full disclosure, I'm working on an educational doctorate right now. And I got to be honest, I don't know that I want to use it, especially in academia. I'm seeing a lot of these issues, across the board. And, a couple of years ago, they're saying, hey, pull back the reins, slow down on all these new programs coming out. We're not going to have the amount of qualified professors to teach at this level. And yet there's still more and more programs coming out. Is there a need for more therapists across the nation? Sure. But at the same time, you've got to do the right things and have the right pieces in place in order to, facilitate a good program and a good class. And I think there's just not enough PhDs or EDDs to fill those roles. And so I don't, we've talked about it on several episodes here that we don't necessarily know what the answer is, but we've got to start trying to find ways to get DPT students interested in pursuing a PhD or an EDD or a DSC, whatever it may be, even if it means tying it into a DPT program and continuing on, or figuring out a way to make it more cost effective to where maybe it's paid for. But yeah, right now it's a scary state, and I don't know that it's getting better at the current time, which is why, like I said, I'm a big question mark when it comes to actually wanting to go into academia and using my EDD for those kind of things. But just real quick, I had one follow-up question for you guys. Are there any high quality studies or evidence out there on levels of reduction and variation or flipped education model in the higher education system that you guys have gone over?
I've taken a course, David Lake and Lisa Schoaf gave a nice course, I think it was at Combined Sections meeting on flipped education. It's a pre-conference course that has a nice reference list that they supported with. And again, it's not so much that has been done in PT education, but a lot of other groups have done it. There is good research about it. So how about what I'll do is I'll send you a reference list. Would that be okay? And if you want to.
Yeah, that'll be great. We'll add that to the show notes. Appreciate that.
And that'd be fine. But basically, what the research basically shows is, at least the big picture, flipped education certainly doesn't lead to any decrement in knowledge. If anything, students, the ones that like it, again, they love the interactivity that goes on in the classroom. Some of them, again, will complain, oh, I don't like taking courses. But overall, I think it's going to be the way that we're going, because it is a whole lot cheaper. You don't have to heat classrooms. You don't have to do things. And the students aren't scheduled to be there at this time. They can do it at home in their own living room.
Nice. No, that'll be awesome. Carol, do you have any follow-ups to that?
Well, I came across a survey of research on the flipped classroom that was done in 2013. It was not done in physical therapy education. It was across the board and in college education. And they came up with the statement that students tend to prefer in-person lectures to video lectures, but prefer interactive classroom activities over lectures. So the anecdotal evidence suggested that student learning is improved for the flipped compared to traditional classroom, but there were no objective measures of student learning outcomes.
It sounds like they kind of want their cake and they want to eat it too, huh?
That's right, exactly. And they're paying for it.
Right.
They want it. One of the things that hasn't been said yet is the way at the University of Miami, what we really stress is the faculty-student connection, and every student is assigned an academic advisor, and the students are evaluated in the classroom both for academic achievement and also behavioral competence according to the professional behaviors as outlined by the profession. When a student is varying from the expectation in the classroom, the Committee on Academic Review is notified and the advisor is notified. And then the student comes before the Committee on Academic Review, either for behavioral or academic problems. And then the advisor and any other faculty that are relevant get involved with that student one-on-one through a whole semester to change their behavior in a way that's consistent with what we expect. So we're really on top of student performance academically and behaviorally, and stress that faculty really care about students, and our graduates come forward all the time saying this is one of the real strengths at the University of Miami, that one-on-one interaction that's available for students. Not all students take advantage of it, but the ones who do benefit. And the ones who are varying from the standard have to take advantage of it. They don't have any choice.
So, I wanted to, again, thank you both for coming on today to share such really insightful viewpoints for our listeners, because to me, it's honestly opened up my eyes and ears to a couple of things that I perhaps had not known about to this level. So I think that's really good for our audience to hear. Now, I realize that the next question I'm going to ask, which is our final wrap-up question that we always ask, I realize that, there might be some overlap with kind of what was mentioned earlier with what you guys were talking about between all the different issues regarding reduction in variation, but even, of course, then going on the matters of starting up programs and all the other issues that we talked about. So if it's the same, that's fine. But if it's something different, that's cool too. So the final question that we ask is, if you could change one aspect of healthcare education, which aspect would you change and how would you change it? And Carol, I'll start with you, and then Steve, we'll follow up with you after that.
I believe that the weakest link in healthcare education is in the ability of clinical faculty to evaluate accurately student performance, even though they have the clinical performance evaluation that's standardized now. For clinicians to be educated as clinical instructors, to develop and mentor students, and then to evaluate them critically. Because what's happened so often is that they don't know how to tell whether a student is really meeting these criteria or not, and they don't spend enough time. And I don't mean to indict clinical faculty. I've worked with clinical faculty. I've been one my whole life. And the good ones are exciting and excited. But the healthcare profession itself has become a business. And the terrible things that have happened since the Balanced Budget Act in the 90s and the move toward insurance companies dictating that we have to see X number of patients in order to be able to stay alive pushes education to the margins in such a way that good evaluation process is not done. Clinical faculty don't have the time, don't take the time, and don't become educated as good evaluators and teachers. So I would
And that's going to be something that's going to happen real easily, real quickly. but Carol, it's that is the issue sometimes. If I was going to give mine, and I'll keep it more into specifically what we're talking about here, is I would say utilize the technology that we have that makes available to anyone that they want, these high quality content experts. Bring them into your program. I think, given the time commitment, faculty will enjoy it a lot, students enjoy it a lot. And so you have to remember, we're lifelong learners because everything is going to keep on changing. And the nice thing is these people are staying ahead of that content, that they can keep on producing these courses so that, again, you can get the highest quality education, or at least that background education to the masses. I would like to add, can I just add 3 little things very quickly?
Have at it, Steve.
One, it has been the most rewarding thing that I have ever done is to work with this faculty. I mean, to work with people like Steve George, Alan Jetty, to work with some of these people, I'm just so happy to do this. And I see this as being good for the profession. I want to also make the statement, I'm not a braggart. I take great pride in what I've got going, but it's not bragging that brings me to this place. I truly am honored to work with you. And lastly, I want to say, when it comes to the financial aspects of it, I look at this and go, we can make this so it's win-win-win. Because if we can do this in a cost-effective way that programs can have it, that's a win for the profession. It's a win for the faculty because they won't have to teach that basic content. It's a win for the company, Rehab Essentials, because it just keeps us floating. And please realize that what I have guaranteed is profits that I make from bundling of courses that universities get, I give 100% of my profits to the Foundation for PT. So they make out on this as well. So I'm just trying to do something that is going to be beneficial all the way around.
Yeah, that's awesome, you guys. I can't thank you enough for your time and for coming on the show today, but could you tell our audience where they can find you online and on social media if they had any follow-up questions or just want to reach out and chat with you brilliant minds?
This is Steve Tepper, and so you can reach me at Stepper, that's Stepper, Stepper, at rehabessentials.com. And the web address for where you can see all the courses and all the information is www.rehabessentials.com.
And this is Carol Davis. I have a Facebook page, Carol M. Davis, and I don't have a website. I am a part of Integrated Physical Therapy and Wellness, and that's www.iptmiami.com. And I also have my email, cmdavis@miami.edu.
Awesome. Well, thank you so much again for your time, you guys. It's been a real pleasure.
Well, thank you very much.
Thank you.
Hey, everybody. Thank you for listening to the Healthcare Education Transformation Podcast, as we greatly appreciate your support to help us advance healthcare education. We are very happy to announce that we have created a new tool to help develop clinicians into better experts. With that being said, we have created the HET Light tool, which LIGHT stands for Learning Integrated Towards Expertise. And what we've done is we've taken our first year's worth of episodes with experts in the fields of healthcare and education, and we've taken one golden nugget or theory on expertise and presented it to you in a very easily consumable format, so that people can take one lesson or nugget per week and map out and plan how to incorporate it into your clinical and educational practices. And by the end of the year, we think you'll be pleasantly surprised at how far you've progressed towards becoming an expert. To find out more, please check it out at pteducator.com/HET, which is also available in our show notes. Thank you again all for your continued support.
Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, Extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.